I have a COPD exacerbation. The lady has a higher BMI. Assessing for dorsal distribution, evaluating that area, and going to do a PEEP study. Very high resistance on and off. Sometimes it goes higher than there 35. So obviously, going to give some Ventolin, Atrovent, make sure there's no airway secretions, and then I'm going to titrate the PEEP. 8, 10, 12. Let's try up to 14 and see what the results show. Looking at here, so yes, she is a COPDer. We're unable to wean her off the ventilator. She's on pressure supports of 18 to 20, requiring that. She gets acidotic. So wondering if, with the family, are we going to do a tracheostomy or not? Are we going to, one-way extubate and go comfort? So it's important to kind of have at least an eyes a bit inside the lung at the distribution of ventilation. Perhaps this lady is in, yes, bronchospasm. There's true airway resistance, but at the same time, there can be dorsal atelectasis. So I'm going to try and set the patient up using the optimal PEEP that the tomography is giving me. Okay, so I've slowly titrated up to 14. All right. The intrinsic, the total PEEP is 19.5, and the PEEP is set at 14. I was noticing like the tidal volume was actually a bit better around 12, but there's definitely, the expiratory flow waveform is a little bit better than before. So let's see what the PulmoVista will show for the diagnostic studies, the PEEP studies. Here we're just looking at the end inspiratory lung volume and the inspiration. This was starting at 8. At 14, we do have a pretty even distribution of ventilation, or it's markedly improved, and it's going to the problem areas. Again, the that maybe this isn't just 100% COPD exacerbation. It's all, bronchoconstriction, airway inflammation. It could be that, which is 100%, it is, but it can also be that she's de-recruited as well a lot of her lungs. So if I can try and correct that, get her optimal, look at the other underlying conditions once the vent parameters are optimal, maybe, this is pretty much what the doctors were asking me to put it on. It's going to help also in the physician and the family members and the liaison nurse to talk about the next appropriate steps. We're at 15 days of intubation, so a decision whether we trach or not, or go another route. We're at that crossroads. Am I going? Okay, yeah. So remember, this is the PEEP of 8. Poor dorsal distribution, that's our reference. When we went to 10, a slight win in compliance where you see the blue over here, and the yellow. Keep an eye on the yellow appearing and disappearing. Those are areas where there's cyclical opening and closing, alveolar instability that can lead to lung injury, so we want to minimize as well the residual volume delay. As we continue, we go to 12, and what I do is I went to 12, but then I kept it there for some time, and I took a second measurement at 12, and we see here's the two 12s. Again, we're winning compliance where? In the dorsal areas. This is what we want to remove from the clinical situation. It is is de-recruitment. We just want to see, you know, we want to optimize obviously the vent parameters and see how bad the airway resistance is really with the COPD. Okay, so we see that there's now consistent distribution to the dorsal regions at the bases. You can see the compliance is gaining in, again, the dorsal region. The PEEP has been increased, so obviously overall there's end expiratory lung volume that is increased. Okay, press pause for a second. Here it's a very clear study. This is the PEEP of 8. Again, not worried at all about overdistension. Pressure volume goes straight up. The white is basically poor compliance in that region, leading to possible de-recruitment. So especially for her, I don't want any white. I don't mind having a little orange, which would say, oh, you know, there's a little bit of decrease in compliance in that area. You have to evaluate it. Are you concerned about overdistension? And the little orange that we have is minimum. We're talking about 6, 10, 14% changes in compliance, okay? Most important is when I went from 8, 10, 12, notice the yellow instability is also present. And when we kept it at 12 just for a little bit more time, the instability disappeared, which is great. There's no more white. That's where the money spot is. 12, a PEEP of 12 is the money spot. And it depends, you know, if you're in a hurry, this is a result you get. Take it off, go do the rest of your job. But yes, if we keep 12 and we don't just do a measurement like after, you know, 2 minutes or 5 minutes, and we can do it after an hour, things can change as well. But for now, 12 seems to be ideal. Just showing you a bigger, when we went from 10, 12, 12, 14, and then 14 is still there. We see that we are winning compliance in only the dorsal region. By increasing the PEEP, we got nothing orange in the ventral areas, which is where the orange tends to appear. So very very trustable results with this monitor. It makes sense with the clinical picture that we're seeing.